All of you. Today, Dr. Surendra is MD DNB Critical Care. He is working as a junior consultant in Medical Hospital Visakhapatnam. I request Dr. Mohan Rao to introduce Surendra to the group. Mohan Rao garu.
Sir, పెద్ద ఆయన ఉన్నారు మోహన్ మహారాజ్ గారు. మోహన్ మహారాజ్ గారు.
Sir.
Let you can introduce, sir.
Even sir, he is one of the senior most anesthesiologists who has done recently with vast experience of oncology anesthesia and he is a DA, DNB and as well as DRNB because he is actually I have seen recently. It's just I don't think it's required for introduction, but whenever I meet along with somebody, they are not recognizing Surendranath. Are you Surendra? They are asking him. Because one important point what I learned was he was 120 kgs weight. He has become now 60 kg weight. So that's one thing everybody should know about it. One important point from Dr. Surendranath. Such a dedicated person to achieve something, and he is definitely good in intracranial things because he has a lot of experience and he's down to earth personality, a nice person, hardworking. So I don't think the rest of the things in future we need to understand because as he is very hardworking at the same time, once he believes something, he doesn't listen to anybody. So he has to mount to that. It takes time. So I really welcome Dr. Surendranath. Start the class.
I request Surendranath to take class on weight reduction. Okay, Surendra.
Thank you, sir. Thank you, sir, for the introduction. I actually I learn everything from the seniors and experience only. Sir. I am not. I will definitely listen, sir. But if I strongly believe it is correct, I don't think. I don't listen to the thing. May or may not be. If I feel it is correct, I will go with it. Whatever it may the consequences. Okay, sir. Today my topic about intracranial hypertension. Very briefly I will tell in how you have to deal intracranial hypertension in the ICUs, what's our role and how to recognize it, and what we have to see in the ICP waveforms and what we can do in the ICU. These are the things I am going to discuss, sir, and what are the types of cerebral edema, how you monitor it. Next, what is the role of hypertonic saline versus mannitol, and lastly, word about the positive and negative trials, sir. And I don't want to discuss about this Monroe-Conley doctrine, and I think everyone knows about it, sir. And one thing I want to discuss is the rate of CSF production in the brain. Usually the volume of CSF in the brain is 150 ml, but the production is around 500 to 600 ml per day. Why I want to discuss this? Patient is rising with ICP, definitely the removal of the CSF is definitely has a significant role to reduction in the ICP. And as a role of critical care specialist, our main goal is to prevent the secondary brain injury. Primary brain injury, we don't have any control, and for secondary brain injury only we have to have a control. And the cause of the secondary brain injury, it is the increasing intracranial hematomas and increase in cerebral edema, and there is increase in intracranial hypertension, and you are adding the superimposing infections or increasing the seizures. Or the other causes that can cause the rise of ICP will be the hypertension or decreased oxygen saturation, increase in the CO2 levels, any hyponatremia or any other electrolyte imbalances, and patient will have a high you are giving the more fluids, or patient having and
Surendra, connection బాగాలేదా మీ దగ్గర? Hello?
is breathing on the ventilator, how is pupils
సురేంద్ర మధ్యలో వాయిస్ కట్ అవుతుంది సురేంద్ర, నెట్ కనెక్షన్ ఏమన్నా స్లో ఉందేమో.
ఒకసారి సార్ చూస్తాం సార్. బాగానే ఉంది సార్, ఒకసారి ఇప్పుడు చూడండి సార్ ఒకసారి.
బానే ఉంది, స్లో చెప్తే బానే ఉంది, బట్ స్పీడ్ వెళ్ళేటప్పుడు మధ్యలో కట్ అవుతున్నట్టుంది.
ఓకే సార్. So just heard about the common just brief examination of the patient who's on ventilator as patient is having some brain pathology. What it takes about a few minutes in the ICU, check how is this pupil size, whether is the eyes anisocoria or is any eye position, whether the patient is having any deviation of eyes, and usually you don't do the corneal reflex regularly, but if you want to check the how is the brainstem, you can put a saline drop on his eyeball and check for the corneal reflex, and how he is responding to how he is responding to pain. If a patient is intubated, you have to see for how is the respiration pattern on the ventilator also you have to check. And this is all we all know GCS. And another thing I want to tell that this is a 4 score. It is not at approved fully, but definitely it has significance as GCS. The one good thing is a patient is on ET tube or tracheostomies. You can examine the other things, the eye response and motor response and brainstem release and respiration. It can also have a good correlation along with the GCS. And you all know ICP normally with the 5 to 15 mmHg, and if any increase in the ICP of more than 20, always it is catastrophic. And always what we measure in the monitor, or if it is monitored the single prick ICP, it usually measures in the centimeters. Always you should know the conversion of the centimeters to mercuries. And we need a minimum perfusion pressure to perfuse the brain, that is cerebral perfusion pressure with a MAP minus ICP. Usually the brain has normal cerebral CPP of 50 to 90. Mechanism of cerebral perfusion pressure from 50 to 90 is the very good auto-regulatory mechanism. If the CPP is less, it will cause vasodilatation of the muscles. If CPP is high, it will cause constriction. So our goal is to maintain the CPP at auto-regulatory mechanism to prevent the secondary brain injury. And the compliance of the curve is the Lang-Fit curve. This is like a brain is like a balloon. If you start inflating a balloon, once it will reach its maximum size, until after above its compliance level, definitely it start bursting out. That's how the brain also behaves. And little bit of ICP waveform. This we will discuss in the later on the monitoring, but I want to tell you what is P1 wave, P2 wave, and P3 wave. The P1 wave is the percussion wave. That is the when there is systolic, the contraction of the heart, there's aortic wave transmit the choroid plexus, and it is the P1. Then the wave it transmits as a P1. The tidal wave after the systolic wave, and the wave that is transmitted to the brain tissues and skull, it will come back and it has a P2 wave. That is it shows the compliance of the brain. That is the P2 wave. And P3 is the closure of aortic wave. That is the dicrotic wave. And what are the causes of ICP elevation? Anything there's a mainly will consist of brain, blood, and CSF. Any increase of these three things cause the rise of the ICP. There is tumor or hematoma or any pus can increase the ICP. ICP, the pathophysiology, it could be the focal one, that is the traumatic one, it could be UDS, SDH, and ICH, or it could be the tumors, or it could be the ischemic or hemorrhagic stroke, or if the patient is having a diffuse brain edema because of the infections, or patient is having post-CPR hypoxic ischemic encephalopathy, our patient has a disturbance in the circulation of the CSF, obstructive or communicating one. Our patient who are having the obstruction of the major venous sinus, that is cerebral venous thrombosis, our patient is having any AV malformations. And one thing I want to tell about the polycompartment pressures. There are the brain pressure also regulated by the pressure in the thorax and pressure in the abdomen. The patient is having high abdominal pressure, will transmit to the thorax. Definitely, it decrease the venous return, increase the back pressure of venous pressure to the brain, and cause a rise in the ICP. And if you are ventilating the ARDS patient with high PEEP, can also hamper the venous return. It can also increase the ICP. So whenever just the patient having two pathologies, brain pathology and lung pathology, just have a caution about how is venous return and compliance of the lung. The compliance of the lung is low, still you can ventilate with high PEEP. If compliance is good, don't guidelines says don't go PEEP more than 13 to 14 because it hampers the venous return, increasing the pressure in the brain, causes the raised ICP. And the word about cerebral edema, just I want to discuss a cerebral edema thing because what is the causing edema in the brain determines of treatment. The vasogenic cerebral edema usually caused by the disruption of the blood-brain barrier. Usually the infections are good with the tumors where our steroids work very well. And the cytotoxic usually because hypoxic injury to the brain, the acute ischemic stroke or any hypoxic damage to the brain, usually it doesn't work for the steroids. And osmolar cerebral edema, usually patient who's having a acute hyponatremia, or patient who are acutely withdrawn from the mannitol hypertonic saline, or patient with fully valvular water intoxication because of there is decreased solute in the brain, increased water content in the solute in the blood, and increased water content in the blood causes the neuronal cell swelling and cause the edema. This can be managed by the electrolyte correction. And interstitial edema, patient has any blockage of the CSF can cause the interstitial edema. Another one is the hydrostatic edema. This hydrostatic edema can be due to the when patient is having very high blood pressure, like usually we've seen in the press syndrome. This can cause the edema of the cells because sudden increase in the blood pressure. So why just I want to discuss these things because this depends. This shows what you are treating also. And this what I already discussed. Vasogenic caused by the tumors and infection, inflammation, and cytotoxic caused by the focal ischemic stroke or global ischemic injury, and hepatic failure and prolonged seizures can also cause cytotoxic edema. And interstitial edema mainly caused by the blockage of ventricular CSF flow, and osmotic caused by the hyponatremia, DDS, and rebound edema. And the patient had raised ICP. How he present in the ICU? Patient sudden complaining of the headache, and patient have sudden vomitings, and definitely there is change in the sensor and low decrease in GCS or what could the 4 score, and patient suddenly complaining I am unable to see. There is deviation of height, there is lateral rectus palsy. A patient has a Cushing stride. We also usually see in patient with in patient is about hypoxic brain injury. We'll see this bradycardia, hypertension, and changing of the respiratory when there's Cushing stride. And this is about a little word about the herniation syndrome. I don't want much discuss about these things, but I will tell what are the important things we should know about herniation. One is the uncle herniation, another one is the transclavicular herniation, and the ascending transdental herniation. The transclavicular herniation, where is the herniation is the outside of the brain, usually doesn't cause much problem for us. It is usually seen in the post-op patient. Another one is subfalcine herniation. The patient will have any ACI infarct, will have an infarct, the edema causing displacement midline shift in the frontal lobe area. It causes the contralateral leg weakness and any behavior just because of the frontal lobe. and any transtentorial herniation, downward displacement of this thalamus, hypothalamus can cause the sudden increase in the urine output, sudden change in the vision, and there could be ipsilateral or contralateral weakness of the limbs. And ankle herniation, usually most of the traumatic brain injuries, there is anisocoria, sudden change in the pupil reflexes. These are all things you should always observe in the ICU for the immediate consultation of the neurosurgeon for the opening of the brain. And where we monitor where you have to monitor the ICP, patient is extremely likely to have a elevated ICP and his neurological activation very poor, which does not allow for meaningful serial clinical neurological examination. Where you cannot, patient is altered sensorium, you cannot monitor continuously. Definitely you need one ICP monitor. And prognosis favorable enough to merit the aggressive care. Patient is having acute liver failure, hepatic encephalopathy, he is going for the liver transplant. Even though patient is having high bleeding risk, still you can monitor the ICP because you have to prevent the brain death for the in the meantime of organ transplantation. Definitely, patient with hydrocephalus, when you will place the EED, you can monitor the both the ICP waveform and you can withdraw the fluid also. And BTF have a guidelines in the traumatic brain injury where you have to monitor the ICP. Patient with GCS of less than 8, any CT, abnormal CT of age is more than 40 years, unilateral, bilateral motor posturing, and SBP is less than 90. You have to monitor the ICP. And you all know contraindication, any local infection, coagulopathies, and any infections, you don't usually monitor the ICP. And we have two types of ICP monitoring things. One is non-invasive and invasive. We know non-invasive, we do the brain CT and MRI and transcranial Doppler and optic nerve sheath diameter and tympanic membrane displacement. I never done the tympanic membrane displacement. It is not that much validated also. Definitely you all, if a patient has any suspicion of any change in sensorium, definitely will take the patient to the CT room and check for how is his salsa and gyre and how is the gray and white matter differentiation. And you will take the MRI. We'll take the MRI, how is the midline shift, how is the cytotoxic edema. Actually, you can very well see in cytotoxic within the MRI. TCD, I'm not having that much experience of TCD. Definitely have done twice or thrice. How is the velocity of the TCD? And now that is the optic nerve sheath diameter. We are regularly doing it. You see if the diameter is increasing, definitely there is sign of increased ICP. And in last class, SAR very well described the ONSD. If it is more than 5, definitely it has a significance. Another one thing, this is the EEG. This is the non-invasive one. It is less, definitely it has a very good sensitivity. If patient in change in the waveform, or patient is having unconscious but not having any convulsive seizures, but patient can have significant non-convulsive status epilepticus. Definitely you can find out in the EEG only. And any change in the theta activity, burst separation, these are all indicates patient is definitely having a very poor prognosis. And next comes to the invasive monitoring. We have 3 tests. One is you can place the catheter in the ventricles, or you can place the catheter in the parenchyma, or you can place the catheter in the subdural or subarachnoid lobe. The only problem with any you are putting any device in the tissue, problem will be the infections and blockade. Or you can measure with the ICP with a single puncture that usually you do in the normal patients. In ICU patient rarely do, but before doing this single pressure monitor, the only thing we should be very much cautious about is patient should have communicating one. It should not be obstructive one, and it should not having any impending transtentorial herniation. I have to connect this PM line to the lumbar puncture and check for the how much centimeter the pressure is, and you can convert into the mmHg. And what is the difference between the intraventricular and intraparenchymal catheter? The intraventricular shows it is usually more accurate and gold standard to check for the raised ACP, and you can every time you can recalibrate it, you can zero it, and you can drain the CSF whenever you have a raised ACP. But the problem will be the infections. And the intraparenchymal one usually have a less chance of infections, but usually it shows the particular area of the ICP. Our patient is having the right ischemic stroke. You are putting the catheter in the left. It may not show that much accurate values. But the problem is you cannot recalibrate it every time, and you cannot drain the CSF. And we all know this EVD. You can place catheter. You ask the neurosurgeon to place the catheter in the ventricle, and you can zero at the tragus, and check for the waveforms. If patient is having high CVD, you can drain also. And this is another type of monitor will be the this is the PbTO2 and SgO2 and microdialysis. I never seen the monitor, but there is a now PbTO2 where you can, when you place a intraparenchymal catheter, you can check the oxygenation level at the brain tissue. Usually the oxygenation normally the more than 25 mmHg. If the oxygenation getting low, less than 15 or 10, definitely it is very critical. The brain is impending for the hypoxemia. And SgO2, you can place a jugular line, reverse the jugular line, keep the tip at jugular bulb. You can take a sample, check for the oxygenation, that is SpO2. If it is low, definitely it has significance. But if it is very high, it may not have significance. But it can be because of you are giving more oxygen, or patient, or it can have brain is not consuming the oxygen also. And this is about the waveforms. If the patient, usually P1 has to be higher than the P2 and P3. The P2, the compliance is decreasing, and P2 is showing higher than the P1 because it is showing that there is increasing the ICP, and compliance is decreasing and his elastance is increasing. Another thing, there's the next waveform is the Lundberg waves, where this is like usually you see in this one of the critical waves called as ST elevation MI in the cardiac. The brain will cause the Lundberg waves. The waves like A waves, definitely it has very significant. It shows the critical phase of the brain, where brain is in the high ICP. Pressure will be more than 50 mmHg for around more than 10 to 15 minutes. It requires some time to make his homeostasis or auto-regulation. If patient is in low BP or higher BP, it needs vasodilatation, vasoconstriction, and to maintain the cerebral perfusion pressure. But it shows the brain is impendingly going for the damage. Then you have to definitely intervene when you are seeing the plateau phase. The A waves always has a critical waves. B waves, it shows there is a definitely decrease in the compliance, and you can see in the patient is coughing or in desynchrony, or patient is training for anything. You can see the B waves, which lasts only for 1 to 2 minutes. It normalizes again, but it is also always, you should be cautious about B waves also, because the compliance is decreasing, should be constant. But C waves is a normal one. You can see in the normal respiration also. You don't care about the C waves. Definitely A waves and B waves, you should always be cautious. This is how this Langford curve shows a patient rising the ICP, and P2 is gradually increasing, where it shows the compliance is decreasing, and if the critical phase where P2 is becoming high, and brain is going to be herniated. This already I discussed. When there is a ICP elevation, this is auto-regulation mechanism of the brain. And the we came to know that patient is having the higher intracranial pressure. Next, what you have to do? Usually we have only brain tissue, blood volume, and the CSF volume, and the closer surface skull. And best will be there's a three-tier approach. It showed good benefit of managing of ICP. Our best first will be you should have a good ICU care, and you should always have a good ABC checking, and head should be elevated 30 degrees. Don't elevate head more than 45 degrees because it further decreases the perfusion to the brain. And you should know compression of the jugular veins, and don't tie the neck very tightly. Keep the head in midline. And if patient has a cervical spine injury, keep the cervical collar in a more not in a too tight fitting thing. It can compress the jugulars. And temperature should be normothermic. Hypothermia definitely dangerous. And you can use the steroids if patient is having meningitis and meningitis, and patient is with TB. You can have a role, and in the tumor also you can. And other pathologies there is no role of steroids. You have to sedate and you have to give analgesia. Anti-seizure medication definitely it is warranted in the patient is having raised ICP and patient is having high risk of having seizures. So BTF showed first 7 days you need to give the seizure prophylaxis. And any patient is having intraventricular bleed or bleed around the ventricles and the white matter, definitely have a high risk of seizure, where you have to give the seizure prophylaxis. And definitely we will always avoid the hyponatremia. If doesn't, these are the best measures where you have to follow in the ICU suspicion of raised ICP. Next, you have to go for the hyperosmolar therapy that we have mannitol and hypertonic saline. And PaCO2, don't go for severe hypocapnia. Less than 30, it causes severe vasoconstriction and further reduce the brain perfusion. And there is no role of less than 30. Keep the normocapnia. If you have an impending brain herniation, you can hyperventilate for a brief period of time for up to 30 or 25 to 30, but less than 30 always everywhere it is a very critical for the brain. It can cause cerebral vasoconstriction. If you have already external ventricle drain, you drain the CSF. And first, if patient have a pathology that is tumor is causing the issue or bleed is the causing issue, ask the neurosurgeon to operate as early as possible. And next, it doesn't work, you have to sedate the patient with propofol or midazolam. And if patient is having dyssynchrony with the ventilator, you have to give the neuromuscular blocking agent. Next, we will go with anything doesn't work, still the ICP is rising, then you have to decrease the cerebral metabolism by giving the pentobarbital coma or severe hypothermia. That I will discuss about hypothermia. It doesn't have any role in the severe hypothermia. It is what already discussed in the ICU. So you have to maintain the calm environment and suction when required only. Don't suction frequently, and better to avoid the Valsalva maneuver. And to maintain the normal apnea, normal pH. High pH always will be metabolic alkalosis, also causes vasoconstriction, decreased O2 delivery to the tissues. So metabolic alcohol is also detrimental in when you're managing raised ICP, normal natriuretic, normal glycemia, and normothermia. And next, told about the osmotherapy, whether to use the hypertonic saline or mannitol. I think by this time, I think everyone knows about when to use a hypertonic saline and mannitol, but I will have 4 to 5 lines about this thing. Then the problem and advantages and disadvantages. I will discuss now with what are the advantages of mannitol and hypertonic saline and disadvantages also. These drugs have a high osmolality. Whenever you are infusing the drugs, always be cautious about the line also. Whether you are using the cannula, it can cause the blockage of the cannula, thrombophlebitis, or if you are using central line, should be cautious. You don't rapidly infuse the hypertonic salines. Mannitol, I think you can infuse, but definitely hypertonic salines, if you rapidly infuse, it can increase the intravascular volume very rapidly. It can cause the pulmonary edema also, if you're having cardiac dysfunctions. And in subarachnoid hemorrhage, if any breach in the blood-brain barrier, mannitol has a controversial hint when there is a breach in blood-brain barrier. There is an intracerebral bleed, traumatic brain injury, because what I read is the mannitol leaks into the extra vascular space. It can create that gap and it can draw the more water there, and it can cause the edema also there when there's a breach. So that's a traumatic brain injury. Intracerebral hemorrhage, definitely they always suggest better to go for hypertonic saline. But if you want to rapidly reduce the brain pressure, always mannitol has its own good advantage. While you are in the operation theater, if you infuse 2 bottles of mannitol very rapidly, definitely brain will shrink, because hypertonic saline does not have that much capability of shrinking the brain like mannitol. In subarachnoid hemorrhage, you can use the both. There is no thing. In traumatic brain injury, definitely hypertonic saline. Acute ischemic injury, you can use both. And meningitis, you can use the steroids as well as along with the patient with raised ACV, you can use hypertonic saline or mannitol. Hepatic encephalopathy, you can use the both. The mannitol, when you are infusing the mannitol, the problems usually what you have to monitor when you are giving the mannitol is this: the osmolar gap. If you are giving hypertonic saline, you can monitor the sodium. You can show this is the osmolarity. If you're having 150 sodium, the osmolarity will be around 310, 320. But if you're mannitol, you cannot see further osmolar gap because it is a glucose molecule. So you have to ask the lab to calculate what is the osmolality. And when you are rapidly administering mannitol, if you withdraw the mannitol, it can also increase the rapid rise in the ICP as well. And when you are infusing the hypertonic saline, you can monitor the sodium. The target sodium usually what will achieve will be the 155. When the problem now we'll discuss what are the advantage and disadvantage of the mannitol and the hypertonic saline. Problems with the mannitol will be usually it is a nephrotoxic, and patient with having the low blood pressure, mannitol may not be the effective one. And you cannot monitor the osmolality regularly. You cannot monitor the osmolality of the serum, and it can when you withdraw the mannitol, definitely it increases the rise in the ICP. And with the hypertonic saline, also there are some problem with the hypertonic saline. If you keep on infusing the hypertonic saline, it can cause the hypernatremia, hyperchloremia, and it can cause the non-anionic metabolic acidosis. And if you're rapidly rising the sodium, it can also cause the ODS. If you are withdrawing the hypertonic saline, if your sodium is rapidly decreasing, it can also cause the rebounds ICP. So it's up to the clinician decision, and it's up to the patient condition what to use, what not to use. Or in some clinicians, they use the both. If they can use the hypertonic saline and mannitol in impending transtentorial herniation. If you want to decrease the brain edema, you can give the both also. But I never seen the recommendation, but in emergency situation, an expert opinion asked about this, you can use when there is impending transtentorial herniation. And next come with, we are done with the hypoosmolar therapy. Next, you have to give us some space to the brain so that brain can expand freely and decrease the neuronal cell, that is a decompressive craniotomy. And you'll always ask the surgeon to do it, and it shows the better results in the traumatic brain injury and the acute ischemic stroke, malignant middle cerebral artery syndrome, where it causing rise in the ICP, prevention of further neuronal damage. Definitely decompressive craniotomy showed a better result. Initially, the outcomes, mortality reduction is there, but morbidity, there is no difference by the decimal destiny. But destiny 2 in the 2014 showed there is a significant reduction in the severe disability, even in the older age people. Better to do as early as possible. And in the traumatic brain injury, DECRA study and rescue ICP study definitely showed a reduction in the mortality, but the morbidity didn't show that much benefit in DECRA and rescue ICP. And patient with having the intracerebral bleed, stitch 1 and stitch 2 trials showed if patient is having any hematoma superficial level, you can go operate and remove the hematoma. It showed a better result. The hematoma is deep seated in the thalamus or basal ganglia, it may not show a best result. And after that, still you are having the raised ICP, then you have to sedate the patient with the propofol or midazolam deeply to decrease the brain activity and oxygenation consumption. If the propofol doesn't work, then the last option, the barbiturate coma, I will discuss in the 4 lines in barbiturate coma. And I think you'll use mostly in the patient is having refractory status epilepticus. After midazolam, you use the thiopental infusion only. The problem with the barbiturate is patient will be very much deep sedated, and definitely it causes the decrease in the blood pressure, and it metabolizes very slowly. Patient with traumatic brain injury, if the patient is have a potential organ donor, if he has a pathology is non-reversible one, you cannot assess the brainstem death as early as possible, where other agents you can assess. Then the problem with the barbiturate, that one of the disadvantages of the barbiturate coma, but it is not recommended in the first line of treatment, is the last line of treatment. And hypothermia, if anything doesn't work, decrease the metabolism by decreasing the temperature. But Eurotherm 3235 trials showed hypothermia in raised ICP didn't show traumatic brain injury, especially didn't show any mortality benefit, but hypothermia has its own side effects, having the erythemias, coagulopathies, and it's increased risk of infection. Always be cautious when using hypothermia. And this is this is how you assess the. We have done this is just a brief outline of the what are the ICP met. Tier 1 will be the best ICU practices. Next will be the osmotic therapy and sedate the patient, avoid excessive PEEP, and Tier 3 therapy will be the, if you want to have a brief period of hyperventilation, for keep the CO2 of 25 to 30, and barbiturate coma and
కొంచెం వాయిస్
decompressive
పెంచవా సురేంద్ర, కొంచెం వాయిస్
Sir.
పెంచవా?
Sir, therapeutic hypothermia doesn't work if barbiturate coma and therapeutic hypothermia, if anything doesn't work. And we'll always measure the outcome of the patients in the neurological patient. There's a GOS scale, Glasgow Outcome Scale, and modified Rankin scale. That's whatever treatment you treat, whether it's decompressive craniotomy and other measures, what is the outcome of the patient in that the end of the 6 months will decide by these 2 scores. And this is my take home message for the today's class. And we have to always, this is Mainly this is the traumatic brain injury patient, but it applies to the every patient, also patient having higher ICP. Have to ABC first and check for the pathology and best practices, hyperosmolar therapy, sedate the patient and drain the fluid CSF whenever it is excess in raised ICP and decompress the craniotomy. Other thing doesn't work, go for barbiturate coma or hypothermia. Yes. Thank you.
Thank you, Surendra. Very nice class. Covering everything regarding ICP and mannitol, hypertonic saline, and all the waveforms. Very good class. Are you monitoring ICP?
Sir, in my ICU, I had done only EBT when I placed 2 cases. I am done when I am doing my residency, sir. But now is the ONSD will measure it. The problem with the problem with comes with the precaution prevent the nosocomial infections. How you are dealing with the EVD drain is the more important. Whenever you are placing a transducer, you are calibrating, you are increasing the risk of infections. I two patients I monitored strictly. I only followed the 24 to 48 hours for the ICP waveform. Definitely, you can see the ICP waveforms. It definitely ICP definitely works.
Yeah.
Whenever
We are monitoring ICP.
Sure.
The monitor is called Godman monitor.
Codman, sir. Codman.
Yes.
Codman.
Codman, and the chances of infection is very low because it is there is no transducer. It directly connected to the probe, and the probe is sealed. It is no way it is exposed to the atmosphere, and the chances of infection is almost negligible.
Yeah.
Only one time you have to calibrate when you disconnect it. Otherwise, you need not calibrate also. I didn't see any waveform on that, but only number is.
That Codman is the one with intraparenchymal catheter, sir. It is
That's
not
what,
the
yeah.
one. It is not the EVD.
Not
Codman
only
and Rossman is the intraparenchymal one.
Yeah, yeah.
You can measure the PbTO2 also in Codman's.
Yes. But we started 4 days back. We put on one patient. We are monitoring that one. When our patient is biting the tube and ventricular dysynchrony, means ventilatory dysynchrony and coughing, then the ICP is suddenly shooting up to 25-30 also.
Yes, sir.
But once you give a punch of bolus of sedation,
Yes,
then immediately it is coming down. So it is definitely very good monitoring system to maintain the ICP constantly less than the, because the outcome is good.
yes.
Huh?
That's how the Lundberg way showed that definitely when you are having A or B, always be cautious. A is always dangerous. Whenever you see the A wave, you should be cautious, and in coughing, buckling, patient is having less cerebral complaints. You need to sedate and paralyze or give them more sedation. Definitely decrease the ICP, sir. That's how monitors works.
Any questions?
Sir, nice presentation, Dr. Surendra.
Thank you, sir.
And one thing,
sir,
as you mentioned that subarachnoid hemorrhage, mannitol will leak into the interstitium so that the ICP will not.
Not in the subarachnoid hemorrhage, sir. I told them when there is a blood-brain, usually blood-brain barrier breach in the traumatic brain injury and intracerebral bleed, intracerebral hemorrhage. Subarachnoid hemorrhage, it doesn't have. There is no. You can use both. What they given, sir. What an article I read, you can use both. But when there is a leak, that is a blood-brain barrier leak, like traumatic brain injury or vasogenic, it can leak the mannitol into the tissues, like it can cause a
3% will not leak.
But 3% have a sodium can have homeostasis, sir. Sodium can easily transmit from here and there. Mannitol does not that much have.
No, same effect it can happen, no? So mannitol, when it is going out and it is decreasing the interstitial edema, then mannitol also can do the same thing.
Mannitol is a big molecule, sir. it cannot come back as early as sodium comes. Sodium is a very small molecule. It is a solute.
Then this
It
is
can,
more dangerous, no? 3% it will go easily and cause more interstitial edema if it leaks faster.
leaks faster, sir, but it can easily maintain the homeostasis because it maintains the gradient, sir. Mannitol does not maintain that gradient.
See, any
Mannitol needs
patient-
metabolization.
So basically these are all theoretical things.
Yes, sir. Yes, sir.
So-
Definitely it is theoretical, sir. Hot error.
See, only thing is why I bought this one is, see now in the critical care where we are working now, nobody is using mannitol. We are using 3% only.
Yes, sir.
So there is studies doesn't show, even though the outcome differences are not much between the mannitol or 3%, but we have looks little advantageous for 3% saline when compared with the mannitol. The adverse effects what they have, and easy monitoring thing like sodium, which can be monitored very easily. Serum osmolarity, usually most of the centers doesn't do a serum osmolarity, they just calculate the osmolarity.
Yes, sir.
So these are all the disadvantages towards the this one
Mannitol, sir.
mannitol.
Yes.
So, and one more thing, as you mentioned, we can see ultimately not to worry much of infections in a patient who is having intraventricular catheter. Ultimately, you have to see that you have to train all your nurses in such a way that the infection precautions has to be maintained and see that doesn't get infection. So intraventricular catheter monitoring can be a good thing of modality, because whatever you do modality, then that will cause infection. So infection control practices has to be strong.
No, nowadays we are keeping number of EVDs, no? So,
Yeah.
you
Yeah.
know, very unlikely the patients, very less number of patients developing infection.
Yes.
That's
Yes.
not the issue.
Yes.
David, sir,
David,
Madam,
సారీ
చెప్పండి మేడం,
డేవిడ్, అయితే మీరు ఐసిపి మానిటరింగ్ చేస్తున్నారా రెగ్యులర్ గా?
started now only, madam.
ఎనీ అదర్ పీపుల్ ఇన్ ద గ్రూప్ డూయింగ్?
అంటే మేడం, యాక్చువల్లీ దట్ పివి రమణ సార్ ఎర్లియర్ he bought that Godman's that monitor, that is one kind of intraparenchymal this thing, ICP monitoring. So I think same thing, I think David he is doing there also, no?
We monitored ICP in care too when I was there 10 years, 12 years back. So same monitor, Codman, now he is doing.
Exactly, the gold standard is intraventricular, as the Surendra said. But thing is, we have to see advantages and disadvantages with that monitor. In CMC, actually, they do intraventricular only, because thing is mainly strict infection control practices we have to do. Only major advantage with intraventricular is whenever ICP is raised, we can drain some amount of the CSF to compensate this. Nice presentation, Surendra. Yes, madam.
Is there a time frame, like a short period కి అయితే we can cut down the infection risk? అలాగని ఎన్ని రోజులు ఇస్తారు యూజువల్ గా?
Usually 48 hours, madam. Usually 48 hours, I think. After that, most of the people worried about this thing, they will this thing. What, Surendra?
Madam, it depends upon the pathology what you are dealing. If you are dealing with a global pathologist, then Codman is very good. Codman has less risk of infection. You can see the global pressure, but sorry, you can see the it shows the global one. If you are treating with the local pathologies like acute ischemic stroke or patient having only pathology at one area, Codman may not be the good monitor. But tumors, if you are thinking about whole ICP, Codman is very good, madam. Extraventricular drain, advantage is definitely SAR told, you can drain the fluid whenever you required. You can keep it, madam. The only risk when you connect to the transducer, the time you're touching the transducer, it increases the risk. Whenever you're exposing to the air, it increases the risk of infection. You can keep the EVD, that is not the problem, but whenever you're exposing to the air, that increases the risk of infection.
Good morning, Surendra.
Sir.
I have two questions.
Sir.
What is the use of mannitol apart from reducing intracranial hypertension? And can you explain more about the transducer drift in treating ICP?
Transducer drift, sir. I don't have a transducer drift, but mannitol you can use in when a transplant patient, they will use mannitol to decrease that one transplant patient, kidney transplant, they will use not kidney.
Liver transplant,
Surendra, I think it is used even for reducing the intraocular pressure, na? For all these glaucoma patients, they use before surgery.
No, it is used for maintenance therapy of inhalation pump in cystic fibrosis.
Okay.
cystic fibrosis.
Whenever you want to increase the osmolality for a volume, you can use the mannitol has it, but I'm not really know about this other things. I might be forget, but transplant patient that they use, I think, the mannitol for transplant patients.
In
I
liver
don't have a
transplant,
transducer deficient.
liver transplant they use definitely. It is a very good drug. They don't use 3%, only mannitol they use. And as Mandula said, glaucoma patients, to reduce the IC, means intraocular pressure, they use mannitol also.
Sir, specifically in hepatic encephalopathy, we use SJVOT monitoring because this is a global pathology, so that will give good results in patients.
Surendra, you said microdialysis, cerebral microdialysis.
Yes, sir.
Really?
You didn't see, no? Cerebral
Yes,
microdialysis.
sir. I didn't see the cerebral microdose, but I read in the book, sir. It shows the lock. They put a catheter like Codman only. They will take sample from there. Either they will connect the catheter, that monitor. They will check the glutamate levels and lactate levels at the site. If it is increasing, definitely there is a pathology. There is a major pathology is going on.
Then
Increasing
they will do
glutamate is the one of the sign what I read, sir. But I never used, I never seen. I seen the Codman in the, just when I'm reading for the exams, I seen the Codman. I didn't see the Codman, sir. But TVD I have done it, sir. But
No, these all are, as Dr. Surendra mentioned, the catheters, parenchymal catheters, where you are placing is more important.
yes, sir.
And what type of pathology is patient? Because
Yes.
if the patient is having an infarct or where the dead tissue is there, if you put there, then all your values will be wrong, will be worst. If you put in a best area, then you will have all normal values, even though the pathology in the brain is going wrong. So there, the parenchymal catheters play, really we need to identify and place it, this one. And the EVD and SGO2, these are all global parameters.
Yes, sir, definitely. SGO2 is a definitely global parameter, sir. But only thing is the high value may not show. It can, if patient brain is not utilizing the oxygen, it can be high. If you are giving high oxygen, it can be high. The mitochondrial death, the high SGO2. That low SGO2 have a very good correlation, sir. If your SGO2 is low, definitely there is.
Suppose if the patient is having a brain death,
Yes, sir.
then the utilization is less.
Yes,
so
sir.
automatically it's like a SIVO2 will be high.
Yes, sir.
So that only says that it is like a SIVO2
SCO2,
is
sir.
like almost like a SPVO2.
Yes, sir. SCO2.
Similar type of parameter.
Yes, sir.
So if SCVOT is low, then you will increase the oxygenation. No?
That indicates the global tissue perfusion of the body, sir. Then you have to check for the lactates and PCO2 gap. You can see whether what is the causing the global perfusion, decrease in the global perfusion. Then you have to treat it. But high SCO2 has a very, it doesn't have any correlation.
SCVOT is normal and SJVOT is low. That means that a regional perfusion problem.
Definitely, sir.
Okay.
Yes, sir.
Then what you will do?
Then definitely, sir, if you know the pathology, you will treat the pathology, or the brain has a very high extraction of oxygen ratio. The hypoxia, you will treat the hypoxia, or raised ICP is there, then you have to manage the cerebral perfusion pressure. You have to go for the decreasing ICP measures.
And what you can do is oxygen supply parameters has to be set, sir, because the SCVO2 is, as you mentioned, is normal, and SGVO2 is low. That means demand by the brain is very high. So you can increase, you can make the hemoglobin 10 specifically in SAH patients, and you can increase the oxygen also, so that the demand is met by the brain specifically.
DO2. You know,
Hmm.
DO2 should be increased.
Yes, sir.
Yes,
Delivery will be. Yes, sir.
yes. See, we have this supranormal deliveries and all these things doesn't have any effect, but I think this we can check into it. You have put two things. One, SCVO2 is normal and SJVO2 is low. That means specific brain parameter is requiring more oxygen.
David said,
Sir, we'll close. Huh?
yeah, with the, no. I just want to ask if with your permission.
Sir, చెప్పండి sir.
Because very good discussion regarding Raman Prasad sir questions and Rani madam's question about how short you can use to reduce infection. And in the city, I think only PV Ramana encourages ICP monitoring, because whether in care or 7 Hills or in Pinnacle now, and he's still being in, and infection is definitely, once upon a time it was more, previously that was the reason stop, now it's showing. My talk and thinking about my question is to any one of you: how many of you have seen demyelinating syndrome of giving a high speed of sodium? And mannitol is a time tested one for since long time. It doesn't have such a great complications, but as you said rightly, maybe for anesthesiologists are used to learn from mannitol, they can maybe in the future it may come to the reduction of glaucoma also to sodium. So I mean, sodium chloride also may come. I don't know, but one real complication of I've seen around 2 to 3 cases is dreaded complication of giving high sodium. That was one thing which I don't know how many of you have seen. Satish sir, you can tell. My question is over.
It's raising. Satish.
Sir, regarding this demyelination by giving 3% saline, as long as the sodium is maintained in the normal levels prior to the start of the 3% saline, it does not have any negative implications, sir. So we can say that between 135 to 150 initial sodium, then rapidly push the sodium levels to more than 155 by infusing high volumes of 3% saline is acceptable. Sudden drift in the values, like suddenly bringing 155 to less than 130, or suddenly improving sodium from 90 to 120, will have this deleterious effects of pontine myelinosis. When we are playing in the normal range, that is initial sodium level is around 130 or 140, then we are purposefully raising the sodium content to decrease the ICP, usually doesn't have an influence, sir. When we are playing in the both the extremes, like hyponatremia is overcorrected. Overcorrection means more than 12 milliequivalents a day, or hypernatremia, overcorrection, suddenly decrease of sodium from 170 to 140, there will be pontine myelinosis. But purposeful hypernatremia, hydrogenic, that is to decrease the ICP, knowing that when their baseline is normal sodium, it doesn't have any negative impact.
No, actually, in a traumatic brain injury or subarachnoid hemorrhage or intracranial hemorrhage, those patients having normal sodium levels before developing this problem. Other patients like chronic hyponatremia, patients like the congestive heart failure, SADH, all these patients have chronic hyponatremic. So they develop a what is called autoregulation, or what is that? All these changes of hyponatremia things happen. These patients, if you give a rapid infusion of the sodium, 3% saline, they will develop demyelination. Whereas traumatic brain injury, I have seen some neurosurgeons or neurologists giving a bolus dose of 3%, like 100 ml 6th hourly, or even 4th hourly, even 200 ml bolus dose also. Because to reduce the ICP, and there is no changes in the neurons or the myelin sheath. Even if you rapid rise of the sodium levels from 130 to, if it is 130 baseline, if it is gone up to 150, there is a rise in 20 milliequivalents in 24 hours, nothing will happen because there is no pathology happening due to hyponatremia. This is the normal sodium levels patient. Rise in the sodium levels will not cause a problem. Problem with demyelination happening in the chronic hyponatremia who having a high rise in or rapid shoot in these sodium levels. Okay, Anna, is it right?
Hello.
Yeah, madam.
Yeah, like our neurosurgeon also says it doesn't cause a problem. So he advises 100 ml TID, 3% saline, over 1 hour, each 100 ml, like over 1 hour only we give. But only my doubt is, patient is anyway, he is unresponsive, he is like that on ventilator, sedated. Even if they develop any problem, how do we identify? Like we think they're normal, like because of neuropathology, they're not improving. They have gone worse. So can we make out the difference, like whether this is because of this or because of neurological, his actual pathology? I don't know, but he said the study shown it's okay to give like bolus of 100 ml like that.
In
Maybe as
hyponatremia patients,
Satish,
madam?
sorry?
In hyponatremia patients?
We didn't, I mean, I didn't specifically notice, but usually they are in 130s, 130, 135 like that. Not very high. If it is over 145, we didn't give.
Patients. Yes,
Madam.
madam. 130, 135 patients. Usually we don't give 3% saline. We don't give because they don't develop any symptoms also. The only thing is you said 130, 135 patients, they are giving 3% saline. That means that acute cases like intracranial hemorrhage or SAH or a severe traumatic brain injury. These patients, okay, they are advised to give bolus doses also.
That's why I'm saying, because they're already on ventilator, sedated, they're
Yes.
not moving.
Yes, madam.
We can't even make
Madam.
out whether there's any